Tēnā koutou katoa, nau mai hara mai ki tēnei hui, tēnei zui a te pōnei. I just want to take the opportunity to welcome you all tonight to tonight's webinar. I hope you're in the right place. This webinar is about bias in healthcare. We're just going to start off with a karakia. So I'm going to ask Kirsten to share her screen. And a really good way to do karakia is and so we tip for you is for one person to be unmuted and everyone else follow along in your own space. So our karakia to open our hui, tū taua mai runga, tū taua mai raro, tū taua mai waho, tū taua mai roto, kia tau ai te Mauri tū, te Mauri Ora, ki te katoa, haumi e, hui e, kai ki e. And so this webinar tonight is brought to you by the Healthcare Home Collaborative. And we're just going to start by introducing ourselves so you know who will be speaking to you tonight. So, ko Irihapeti Mahuika, tōku ingoa, he uri tēnei no kaitahu, no te taipotini, te tauraka waka a Maui tōku marae, kei raro i te korowai o te hapu o ka te mahaki ki te taipotini. E mahi ana hau ki Pegasus Health. So my pepeha brought us over from the west coast of the South Island, right down a little spot called Bruce Bay, in between the two glaciers, and that is where my marae sits. So that's my whakapapa and where I come from. I currently live in Ōtautahi in Christchurch, and I work at Pegasus Health. And my role there is the Director of Holder Māori and Equity. And so I'm really privileged to be able to chair and facilitate the webinar tonight. So I'm going to hand over to Hemaima, who's one of our kai kōrero, and ask her to introduce herself. Kia ora, Hemaima.
Tēnā koutou katoa, e mihi ana kia koutou. No tai toke rawa hau, ko ngā toki matawhaoroa te waka, ko hekurangi te maunga, ko tau mārere te awa, ko te meria te marae, ko Ngāti Hine me ngā puhi toku iwi, ki te taha o toku pāpā. That's on my father's side, my people are from up north. And on my mother's side, ko Ngāti Kere me Ngāti Pihere, Ngai Tahu, me Rangitāne oku iwi katoa. So me mihi ana kia koutou. It's wonderful to be here this evening. E mahi ana hau ki Mahitahi Hauora. So I work for Mahitahi Hauora, which is situated in Whangarei, and I play the role of nurse director there. E noho ana a hau, I live currently in Kaikohe, and once again, really excited about being here this evening. Tēnā koutou, tēnā koutou, tēnā koutou katoa.
And I'll hand over to Kyle for him to introduce himself as well.
Tēnā koutou katoa, no ko te rāna oku tūpuna, e tai mai oku tūpuna ki Aotearoa e te tau tekau mā waru, rima tekau mā ono, ko Roy Donaldson rawa, ko Audrey Christie oku kaumātua, ko Des Eggleton rawa, ko Elspeth Dons oku kaumātua, I tipu aki au ki Waima, e noho ana au ki Ruakaka, ko Kyle Eggleton taka ingoa. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So I'm a rural GP based in Northland. My ancestors come from a number of places, including Northland. I grew up in a place called Waima and live in Ruakaka. I'm the Associate Dean of Rural Health at the University of Auckland, and most of my work is based in the mid-north of Northland at the moment.
Ka pai. And so as I mentioned before, the title of this webinar is around bias in healthcare. And it was a really interesting journey to come to the conclusion of what the title would be. We talked about things like unconscious bias or systemic bias, even some words like racism came in there. And what we decided is that we would acknowledge right from the right at the beginning that it's not necessarily about the word that we're using, because sometimes we can get stuck in the conversation around whether that's the right word, whether it's the system that has biases, or whether it's individuals within the system, or whether it's both. And so really what I want to invite you to do tonight is to open the conversation and your own thinking in your own space around being focused on the concepts that underlie what we talk about. We are in an amazing space as a country. We really are in the most opportunist time that we've ever had in public service sectors such as healthcare, where we are asking ourselves those critical questions as to the why that we find ourselves in this country. So in Aotearoa, New Zealand, we know a lot of the data. We're not going to spend time digging into that. I'm assuming that everyone who works in healthcare understands that there are some gaps when we start to look at health outcomes for different peoples in different communities. And this webinar tonight is really about unpacking some of the reasons why. And so it's really important to base ourselves in this. I want to acknowledge that this journey is a really exciting one for us as a country and as healthcare providers, but it's also can sometimes be a hard one. And so I really wanted to start by saying thank you so much for all being here and opening yourselves to walk on that wobbly bridge of what it is to learn and unpack what our own personal biases may be and how they contribute to our work that we have every day with our people. So I'm going to hand over to our first kai kōrero, Whai Hemaima. She is going to share her screen and take us through a bit of a kōrero from her experiences. So kia ora, Whai. And don't forget that you're on mute.
Unmute. I'm hoping you can see my screen. Just wait for that to flip into, okay. We can see my screen? Yeah? Okay. So I'm going to take you through a little bit of an intimate journey this evening, because I think for many of us, we've had the opportunity to challenge ourselves on the intelligence and the theory of bias. And my experience and observation working with staff, with nurses, and working in our own organisation has given me some insight and helped me to realise that even though we might have the theory and the intelligence about what our biases or stereotypes or prejudices might bring us, we are a little bit vulnerable, and we therefore don't necessarily embrace the moment to step into a conversation that addresses what having a bias or owning our judgments might do to us. And as professionals, I really invite you to step into a space that helps you to feel something that might give you an opportunity to make a change and be a leader in your space around unconscious and conscious bias. So just as a little tip as well, I have written some notes into every slide. And so when you receive the pack, the slides, you'll be able to print out and see all of my narrative as well. And please feel free to use that in a way that can help you to think about some of the things that I share with you this evening. So here we go. I want to start probably in a place that you might not have expected this evening, but I'm going to start with the genesis of man. So the ancient ancestral story of mankind, which was passed on to me, tells of the creation of humans that was fashioned from the dust of the earth, formed and shaped. Then the Creator breathed into the form of humans, to which they took in the breath of life and sneezed. Ti hei wā Mauri Ora. This is the expression that came from my ancestors, marking the moment that breath came into humans. And now From then till the present day, we greet each other with Mauri Ora, life to you. Oh, gone too far. So many of you may recognize this, this little diagram. It's an illustration that's attached to Pai Ora in the ministry document of He Korowai Oranga, and appears now in the updated version of this, or this piece of work, which is Whakamaua. And I just want to point out to you at this time, you know, Pai Ora represents healthy futures for Maori, and it's presented to us so that we can, gives us a bit of a direction and a guide, and helps to lead us into the thinking that will bring about healthy futures for Maori. By responding professionally, clinically, and humanly with an awareness of our contributions to support, as you can see in this diagram, Mauri Ora, which is healthy individuals, whānau Ora, which is healthy families, and then Wai Ora, healthy environments. Those three things together bring about Pai Ora, healthy futures for Māori. So, Ti Heiwa Mauri Ora, Atua breathed life into man, he sneezed and he became. And with breath came life, and so we recall that, and we celebrate life to you. Tamati Kruger is a well-respected elder from Tūhoe, and I really enjoy his narrative about many things, but on this particular occasion tonight, I want to present to you his thoughts about Mauri Ora. And he says that Mauri Ora is feeling the thrill of being alive. When I first heard that from him, I just thought, wow, that's a really lovely expression, you know, to feel the thrill of being alive. So I took that little thought and I wondered what would happen if, as a nurse myself, as a professional in health, I wonder what would happen if every person that I greeted, that was my sole objective, was to help them to feel the thrill of being alive. So in this place where the rapture of life is full, Mauri Ora can be restored and sustained. And we're talking about the sustainability, or the perpetual fountain of that is regenerated by our goodness to one another. This comes from an unconditional acceptance of who people are, others understanding what is important to them, and having the self-efficacy to determine life direction. So I want you to just pause for a moment and consider a time in your life when someone or an event breathed life into you. How did that feel? Your family and friends, perhaps it was your birthday and you just knew that every effort was made to focus on you. Or perhaps your colleagues in an employer, or other nurses in your team, or other professionals may have celebrated an event, a significant achievement, and you felt really encouraged and uplifted. So I want you to consider and recall the elation or the appreciation, perhaps the value of your contribution. And do you recall the emotion or the high and the unconditional acceptance of those who were around you? Did that celebration put wind in your sails? Did it carry you a few days? Did it make you feel hopeful? Did it make you feel valued and more able? Did it empower you and strengthen you? And did it give you permission to try again and expand yourself? So Dr. Juliet Rumblesmith is an epidemiologist working for the ministry now, at least I think. She's still working with the ministry. She leads out with the instruction that services can approach inequitable health outcomes in 3 specific ways. So she says that we can address health inequity by through our systems. So here, health system and services. We can address it through recognising the needs of individuals, whānau, or our population, and provide services and support that help them directly. And thirdly, we can support the health workforce, so services can focus on the patient-provider interaction. So Juliet Rumblesmith reminds us that the most significant point of influence for change is to be able to manage our own approach to the patient, for therein lies significant power in the bond between you and the patient. So hidden in plain sight, there is an opportunity to shape our engagement skills and to breathe life into the patient experience. We have learnt that for Māori, there is really an obvious thing to do that we can do, but we don't necessarily do it. And this is to see every encounter as a Modal experience, an opportunity where we breathe life into the patient. It may be a 20-minute window, it may be a half an hour or an hour, but it is nonetheless a window of opportunity where we can further encourage. Through our authentic engagement, we can uplift someone and put something there that may not have been there before. It's an opportunity to bring into harmony a suite of skills that come into play when we realize the mana that exists in the power and influence of that relationship. When we tune ourselves into the experience of the person, realize the role that we play in lifting and sustaining the patient to a position of power and self-efficacy for their own personal leadership, things can change. This kind of contribution will bring the patient back to you voluntarily. They will negotiate with you their challenges and take a stronger lead in their journey. With your trust and respect for their preferences and values, you can make a difference, and you may reduce time in other areas and matters of their care. Where there are pressures and limited time in the rush of the moment, you might just forego this valuable opportunity to enlist the patient as the driver to their own miracle of change. You may sacrifice the moment for richness in exchange for the satisfaction to just move on to the next task. Consistent feedback from clinicians and nurses, just like ourselves, include having limited time to address multiple complex issues, feeling overwhelmed, and having limited capability to adapt to new information. So hidden in plain sight is the opportunity to recognise that we are keepers of a vital ingredient, which is to unleash the untapped contributions of the patient themselves, simply by connecting with them with the expression of how thrilled you are to see them. The expression of Mauri Ora is not a tool or a gimmick to make people feel happy, but rather it is an opportunity to express that you are thrilled to see them. It is to infuse every fibre of their being with your wish for life to you and Mauri Ora. This subtle difference communicates a deep sense of value. People need to feel like they are going to have a positive, meaningful, and relevant health experience with you. The encounter with the patient is to not skip over the value of deepening connection, but to really listen, to really focus on them, and to breathe life, hope, and encouragement, to lift patients so that they are permitted and encouraged to make decisions that advance their progress to positive health benefit. Try again and again and again to stay in relationship. Critical reflection is the key. Recognize when problems arise. Accept your contribution to the change that can be made. Consider your biases and how they play into your engagement so that you can stay connected. The patient can be a great teacher in this moment. What matters to them? What can you learn? How can you work together? Shift the starting point of the service. This is not just shifting the locality of services, but this distance can also represent heart space. Once in the same heart space, consider how you can bring information and intervention to the patient's level. Consider how you shift the power from you as the dominant, stronger person, delivering care to making them the decision maker, in charge, the leader, the driver of their own destiny. So as we sharpen our awareness of the existence of our biases, we become less unconscious and become more empowered to consider the changes we can make in ourselves by responding to the separations that we create through our judgment of others because of our own values towards them. Unconscious bias refers to the stereotypes, both negative and positive, that exist in our subconscious and do affect our behaviour. Unconscious bias causes us to filter our clinical responses that can negatively affect the people that we serve. Common types of unconscious bias, as you can see there on the slide. Non-compliant patients, however you want to pitch the language of that, there are patterns or categories that you might fit people into, and it may be some of those. Regardless of that, the patient catches a glimpse and sees through our professional facade as soon as we roll our eyes, as soon as we frown at the detection of a smell, when we reconnect with a previous poor, challenging encounter, you know, that experience comes forward in front of us. As soon as we show our distaste for their appearance in any way, or behave somewhat guarded as though they were bringing with them something that you were not prepared to support. Be it body weight, being a smoker, skin colour, job, tattoos, stigma relating to age, culture, sex. There is something about detection of difference that is very quickly displayed in our facial expression, our body language that cannot be disguised, because the human touch is a poor liar. The patient has a finely tuned unconscious bias too. They too have a sophisticated system of detectors that warn them of their own difference from you. So they caught you before you caught yourself. They judged you too, and in a split second, they too began to respond to the distancing game. There is a choice to be made here. It is a choice for connection or separation, and it begins with our own awareness of our biases. I'm hoping that as I raise these, that you are thinking tenderly of your own experiences with people and how you might respond, how you might be responding. So the patient catches a glimpse and sees through that facade, and we begin to make some changes. So we want to be able to be ready to make the choices that are available to us, which is simply to quieten ourselves, be still in ourselves, and think again, reflect on our behaviour, reflect on the response that we are getting, and ask ourselves whether or not what we are experiencing is a Mauri Ora response. Is this an experience where we have managed to breathe life into them? So racism is also a particularly strong bias to hold, and we take responsibility for how we act and behave with others. So as you can see here at the bottom, you know, unconscious or conscious, overt behaviour or inadvertent behaviour. So how do we know when you have an unconscious bias if you are unconscious? We need to maintain a vigilance to detect our own and others' biases. Can I stop myself? I'm just going to remind people that someone needs to mute, please. Just have a check and see where you're at. So yes, you can learn to catch yourself. Our unconscious bias is manifested in our little irritations, our impatience, and our blind spots. So we can learn the skills the same way that we learn how to understand signs and symptoms of disease or a state of unwellness. We can learn the signs and symptoms of unconscious bias or conscious bias. And it appears in us through our little irritations. As soon as we feel an irritation or something that is separating us from people, something that makes us step back from people, or as I've mentioned earlier, roll our eyes or have all of these other expressions, these are signs and symptoms of our bias. And you can teach yourself to see that. This little slide just puts together the way that I see clinical competency is that we can learn a set of technical skills. This is the science of our work. So clinical competency is when we have learnt procedures and steps of things. It's a technical process and we can follow that really competently. That's the science of our work. But cultural competency is a little bit different because it requires us to engage our whānau and our compassion. So both clinical competency and cultural competency is important in widening our awareness of the presence of implicit bias, stereotypes, and judgments. Clinical competency being the science of our work, learning procedures and processes, and teaching ourselves to recognize important signs and symptoms of disease. Detecting and responding to bias is both a practical clinical competency and needs the generous, artful approach of cultural competency in order to respond with grace, dignity, and compassion. Detecting and managing our biases is a technical skill that can be learned in the same way that we come to understand and to detect the presence of disease by the smell of a body odor, perhaps breath, the discoloration of skin, the look of a posture, pace and gait of walking, sadness in eyes, the quiver of a voice. The art of critical reflection should be called upon in every encounter as a clinician's best friend. If Mauri Ora is to happen, breathing life into a patient or provider interaction will help us to thrive and flourish in that engagement. Okay. This is where I get to pause, and I'm going to throw the ball to Kyle in that court. At this point, I'm really excited to hand over to Kyle, who is one of my favourite Northland GPs, and I look forward to hearing, and I'm sure you will, how we put together our understandings about bias and stereotypes and judgments into practice. So I pass the time to you, Kyle.
Thanks, Hemaima. If you can stop sharing, then I can. Thanks. Well, I think Hemaima's done a fantastic job of outlining an approach, and what I thought I might do is talk about how you might want to use that approach in yourself, and use some practical examples from my own journey, and talk about how I've addressed and continually address my bias. So just some background. As I said, I'm a rural GP working part-time and up in Northland, and I'm Associate Dean of Rural Health at University of Auckland. My research interests are around equity and addressing Māori health inequities. So I'm going to talk about some of the principles of the Modal Window that Hemaima has discussed, with a few modifications. And the first element that I want to touch on is reflection. And reflection for me has involved a number of steps. And the first is really about checking our own history. One thing I've learned is that we're not individuals floating along, undertaking our own journey. Rather, we come with our ancestors behind us and in front of us. And it's important to see how our background and our family history might have contributed to inequalities and inequity. So my own family's history is that on my father's side, we settled in Southland and Taranaki in the mid-1800s. And on my mother's side, my ancestors settled in Northland, also in the mid-1800s, just a decade after the signing of Te Tiriti. And this is a photo of Marangai, which means the east wind as it faces east over Okaihau. and it was our family homestead built in about 1870. This is my great-grandfather's storage box built from a kauri tree. Ironically, it was a kauri tree that killed his father, my great-great-grandfather, who was involved with the logging of kauri. So my own family was involved essentially in the colonisation of land. And this colonisation involved not only the remodelling of land, but also renaming it. So Donaldson Road, named after my Donaldson family near Kaihau. Scudder's Beach, named after my Scudder family who ran the Kirikiri Stone store. And McLeod's Bay, where my McLeod ancestors settled in the Whangarei Harbour. And these names have been stamped over and supplanted the original Māori names and imposed the Western world view over the landscape. Understanding privilege is another step in reflection. Privilege is sometimes a difficult concept to grasp, as people often think privilege as relating to wealth and might say, well, I'm Pākehā and my mum was a solo mum and we had no money, so we never had any privilege. Privilege really refers to systemic and interpersonal advantage that works in concert with systemic discrimination and marginalisation. So in this picture, I'm the cute white baby in the centre of the picture. I always thought this photo was quite humorous, but there's something deeper going on. What privileges operated at this time that allowed my mum, who was the school teacher, to bring her baby to work? She brought my sister to work as well from the age of 9 months. Would the Department of Education in the 1970s have allowed a Māori teacher to have her children in the classroom for the entire time? Over the years, I've done a lot of reflecting on my own privileges through art and writing and poetry. This piece of structural art was made after viewing a piece of work by an Aboriginal artist in Melbourne, and then thinking about the stories that many of my patients had and contrasting their experiences to mine. So these are all true stories that my patients told me, and I turned them around to reflect. Although I'm presenting these elements of reflection in what appears to be a linear pattern, in fact, the first thing that I did was to audit myself. I was working as a GP in a rural Northland town in a mainstream general practice. I was quite young in my career, so probably in my first year of fellowship. And what I thought I'd do was audit my own prescribing patterns as part of the requirements from the college for our MOPS points. And what I found was that my prescribing was inequitable. I had lower rates of prescribing appropriate medications such as statins to Māori. And this led me to looking at inequalities more broadly. And I quickly realised that the structure of the primary care system was racist and that there were other models of healthcare delivery that could potentially address health needs in a more equitable fashion. I actually ended up setting up a free health clinic in the local community, working with a Māori health provider. And these clinics slowly expanded over time to include 6 rural outreach clinics that we were delivering with a mobile van. One of the things I learned from my audit was that my thought processes would often homogenize people, such as making assumptions that, for example, Māori would not want to take medication. And so I wouldn't offer medication in the first place. What I had to do was constantly challenge my thoughts and become conscious when I was homogenizing and stereotyping people. Connecting to people and patients is critical, and I see that the connection starts not with the health practitioner, but with the practice environment itself. A number of years ago, I undertook a research project interviewing vulnerable patients about their experiences in entering a practice and engaging with a receptionist and waiting in a waiting room. And what I did is I got participants to draw their experiences, and then we co-analysed the pictures together. So this is one of these pictures. What I found was that participants were overwhelmingly nervous about entering waiting rooms and saw waiting rooms in the practice environment as being unfriendly and unwelcoming. And what they wanted was a reception process that was highly welcoming and receptionists that treated them as family. Treating someone as family might be easier said than done. And one process that can replicate this, or at least initiate it, is whakawhanaungatanga, which is the process of making connections. And this is something that I routinely do in my consultation. For example, I would ask someone where they grew up or where their family lives. And I think it's probably better to frame the question this way rather than saying, where are you from? Because that can have a misunderstanding sometimes. Just going back to my Waimā picture, as an example of whakawhanaungatanga, I would often find out that patients have links to Waimā, where I grew up obviously as a child, and it's not uncommon. In fact, it happened last week, where in the process of whakawhanaungatanga would discover this, and patients would find out where I came from, and they'd say, oh, I remember you, you're the little white boy whose nappies I used to change. Sometimes a very humbling experience to realise that your patient has seen you naked. Hemaima talks about the Mauri Ora moment. For me, this is about being alive in the moment with our patients by revealing our humanity and developing the deeper connection to patients at an almost spiritual level. One way in which I describe this is being in tune to someone's emotions, to empathise, to pay attention to someone deeply, and to use all our vast array of communication skills that we have as clinicians, including our non-verbal communication skills, to connect at this deeper level. By seeing the person as a person, not a demographic, I think it's possible to overcome bias that we might hold. Some things that I do in a practical sense is I don't ever look at my computer when I'm doing a consultation. If I have to, I'll indicate that I need to look at the computer, the reason why, and I'll apologise. I'm comfortable using silence and touch as well as part of the consultation. Taking someone's pulse can be a safe way of touching and connecting physically to people. Hemaima is also probably going to talk about sharing, preparing, supporting, empowering. I think that one way to do this is to move ourselves away from a primary care or medical model to a comprehensive primary healthcare model. And there's a distinct difference between primary care and primary healthcare. Primary care includes general practice or pharmacy or midwifery, etc. Primary healthcare relates to a philosophy of empowering communities and patients. An example is shifting away from doing health education, where we tell someone why they should stop smoking or lose weight, and move instead to a community empowerment model, where we engage with communities and understand them and facilitate their solutions. The trouble with the health education approach is that often this becomes victim blaming as individual risks are looked at and can feed our biases. Another example is shifting from consumerism, where we get patients to fill out satisfaction surveys, to something called democratic participation, where patients and community voices are involved in our governance or committees or oversight. And this approach also challenges our preconceptions, as we have people that work alongside us in a different role from our communities. I'd like to end my talk by talking about another way of challenging misconceptions and bias, and that is by acting as an advocate. When we can advocate for someone different to us, we're allowing ourselves to understand their position and the shoes that they stand in. Part of this advocacy is standing up for things that aren't right and challenging others. And I have to admit, I'm not particularly good with this at times. I'm going to end with a poem I wrote about one particular encounter where I wasn't brave. It involved a GP who said some particularly vile and racist things in a group of other GPs, and I felt so confronted that I could not respond in the manner that I wanted to, and I felt sick afterwards. And this poem is called My Response to the Racist. He stared at me intently with fervent eyes, gleaming brightly, and I watched his lips spit out the words, twisting darkly. I felt his sounds touch my soul, ripping quietly, but my voice was silent, lost in indecision, blathering me stupidly. I snuck away, avoiding his shadows, clinging coldly, and wept some tears of anger and rage, feeling cowardly. I imagined myself being the opposite, feeling bravely, clinging hotly, blathering wittily, ripping loudly, twisting lightly, gleaming darkly, as I stared at him intently. So I'm just going to finish there. That's my contact details if anyone wants to reach out to me and talk to me about anything at all. Thank you.
Tēnā korua, Tēnā koe, whaia Hemaima. Thank you so much for taking us on the journey of connection through wairua and whakapapa to really reinforce the need to be authentic and just human in our relationships with the people that we serve. An acknowledgement to you as well, Kyle, for your very open and honest and vulnerable sharing of your journey and the journey that you've been coming on together. I have the real privilege of bringing some of the themes together from the two speakers this evening. There is an opportunity, if you have any questions, in the chat function to ask those questions, and we can ask either via Hemaima or Kyle to answer those. There's been lots of comments coming through as well that you'll be able to see, lots of statements or comments of agreement and acknowledgement of the messages that you've shared. And yeah, I think I just really want to acknowledge everyone's connection to that kōrero. For me, the things that I heard that just ring so true are around how we can ensure that our whakapapa and our journey and all of the experiences that we've had as people are brought into that interaction with our people we serve, and we are able to connect with our people in a really authentic manner. The words like authenticity and empowerment through those contributions and connections are absolutely vital. And so I think that's a really big message from tonight's webinar, that we all need to take away that opportunity to sit, reflect, check in with ourselves, challenge our thoughts and our colleagues, and really take that time and opportunity to connect in that really human way. There is a question that's just come through in terms of, it's asking, can you share how you would work within a general practice team to identify bias in practice and address this? Is either Hemaima or Kyle wanting to open that one, answer that one?
Yeah, I'm happy to. Kyle talked a lot about reflection, and as I do as well. So in order for reflection to happen, you have to make space. You've got to create space for that, and you've got to do that deliberately. So I imagine that in the moment of our awareness, if we could be vulnerable in the tea room and create a culture of learning, then you would be able to talk with your team and your colleagues and say, oh, look, I had this experience, you know, what do you think? I think it's an opportunity for you to, I really loved what Kyle said about, you know, Mauri Ora and about the reflection, the opportunity for reflection blesses us with humanity, and the response that we get back from that. Like when I think about manaakitanga, I think about what I'm giving to you, what you're giving to me, what I'm giving to you, and we go like this, you know. So I'm sharing an experience with you. My expectation would be that you would be generous with me, and then I could add to that, and you know, and then you'll give me something back. It's a very it's not just a wairua experience. It's an intelligent opportunity for us to learn how to articulate what we're experiencing, talk about our discomforts, say what is happening, and then be able to share the way that you experienced something, and then let others share their compassion with you. I think over the last little while, I think especially with COVID, our workforce is fatigued, tired, and compassion. Many people have said that, you know, we're lacking compassion. Here's another opportunity that demonstrates that we can change the space. Yeah, so that's the first thing. Make the space for reflection, make it regular, have lunchtime, break times, talk about stuff, and go there. I talked about Mauri Ora as in breathing life for our patients or the people that we serve. Just remember that the people in your team are also people that you serve. Mm. And I really love the poem that Kyle shared, because helps us to realize how much how much generosity or compassion we need to have to work that space.
And I think it connects back to something you mentioned earlier, Fire, in terms of feeling the thrill of being alive and the real value of your contribution, your individual contribution to the context or the space that we find ourselves in healthcare. So I really love that Mauri Ora, the breath, the thrill of who we are, and we have power and opportunity. I think I wanted to also acknowledge in the comments earlier some of the kōrero around, people acknowledging that the less that we know about people before we meet them, the better. And there was a comment recently around the expectation of collecting data, and maybe a question mark over whether that helps shape possibly sometimes our biases as we enter into those interactions. When we have a piece of paper that says that this person is ABC, do we shape in our minds what that looks like? So as we've heard tonight, it's another opportunity for us to pause, reflect, and consider, from a really empathetic point of view, whether that's going to shape our interaction before it happens and while it's happening. I'm just looking at time and really mindful of we're nearing the end of our time together, which just seemed to fly by. There is an opportunity. I'm going to ask Hemaima to bring us to the conclusion of our kōrero tonight, if that's okay. And I'll just get you to unmute again, Fire.
Thank you. Just before I go into closing this, just want to mihi to Kyle and appreciate how you just knit all of that together. That's really great. So thank you. Just a couple of slides in the end, because a call to action is a call for change. A call for change is a call for unexpected vulnerabilities to appear. And so we can get really practical and, do some really simple exercises. This slide just supports how important it is to have opportunities for clinical reasoning, have an opportunity to present case studies and structured reflection. It sort of just carries on a little bit from my comment just a few moments ago. So this slide and this content might be helpful to you. Can you move that, Kirsten? Thank you. So I didn't put up the Modal Window, but I have talked about all of the components, and as did Kyle. So for those of you who've never seen the Modal Window, it is a list of 7 little tasks, if you like. If you think about the Modal Window as being the opportunity for creating this special recognition of the moment for change can happen in this space. And so 7 little things that you can do. As Kyle mentioned, connect with people, demonstrate and show them the thrill of being alive. Give them the Modal experience. Reflection is the 3rd thing, being able to reflect on our own thoughts, our own practice, our own biases, etc. The 4th thing is then to be able to, once you've created the space, you've now got a clear runway, if you like, to deliver your clinical intervention. So you can hear all of the efforts that go into creating connection at the beginning and rapport. That therapeutic rapport is what is going to help you sail through the next, clinical steps. The fifth thing is to stay connected. So all the way through our engagement with people, we have to stay connected. We have to not lose sight of where we are trying to go to with the person. And Kyle mentioned about sharing, empowering people, preparing them with all of the information so that when they leave you, they can drive their own journey. And the last thing is to evaluate the encounter and learn. So this little slide falls out of an outcomes rating scale by Scott Miller, and 3 things or 4 things that we should reflect upon. Now, this is a patient-focused evaluation, so this is something for them to do, but it is something that you can reflect on, which is reflect on your relationship with people. How do you think your relationship went from 1 to 5? And quite often, if you don't check, you'll discover that you're at a difference. You might feel that you did really well. The patient might have a different view. So how was your relationship? Goals and topics. So did you talk about the things that were important to them? So really important at the end of your consult to check. Did we talk about the things that were important to you? Did you achieve the things that you came to see me about? The third thing, the third question, approach and methods. If you haven't recognized, this is the cultural question. Have I used an approach or a method that is suitable and appropriate for them? And let them express that. That's the cultural question. And lastly, overall, is there anything missing? Are you leaving here fulfilled, or do you have everything that you came for? Is there anything that we didn't do? So that's my little take on, our call to action as we put together the components of an experience that might help people to feel Mauri Ora, life to you. So tēnā koutou. Oh, and just as an end thing, I'm not sure if you are familiar with the Ora presentation for the healthcare homes. There's this beautiful flourishing picture of Ora, and I love to use this by putting it right against the Ora model coming out of Whakamaua, because that is a really earthy, bare state that suddenly flourishes because we have healthy individuals, healthy families, healthy environments, healthy futures. Pai ora. Te tēnā koutou, tēnā koutou, tēnā rā tātou katoa.
Tēnā koe Hemaima for that call to action for everyone. Such a meaningful and connectable kōrero. I wanted to offer Kyle with you, but we've only got a few more minutes, but were there any last comments or kōrero from you?
No, I don't have any further comments. All good.
Hapai, and as you will see in some of the comments that are coming through, some real connections that have been made tonight on a personal level with the kōrero that's happened. So I just wanted to take the opportunity to thank you both again, Hemaima and Kyle, for your kōrero tonight. I wanted to offer the opportunity for everyone to know that on the Healthcare Home Collaborative webpage, there are lots of resources, including a webinar that Hemaima ran about the Mauri Ora window. So when that was mentioned about, there's one there that you'll be able to rewatch, I understand. And yeah, really just an opportunity for us to really connect with the messages in the kōrero tonight. So thank you all for being here. Thank you to the Healthcare Home Collaborative and the organisers behind the webinar, and just a real acknowledgement of us all in these times where, as Hemaima said, we are all very fatigued, trying to do the best to protect our our people that we serve. So we are going to end off our evening tonight with an ending karakia to close the evening. So join me in that. Kia hora te marino, kia whakapapa pounamu te moana, kia tere te kā rohi rohi I mua I tō huarahi. So kia ora everybody, and enjoy the rest of your evening and the rest of your week, being Friday tomorrow. Ka kite.
Ka kite.